Assalamu alaikum. What is the recent medical evidence for selecting an antibiotic if this is needed in the treatment of group A beta hemolytic strep and acute pharyngitis causing sore throat? Not all cases of sore throat would require antibiotics. In fact, less than a third of the cases of acute pharyngitis and tonsillitis would have a bacterial pathogens. And even then, most of these cases would self-resolve within a week without a need for antibiotics. All the guidelines would advise the use of antibiotics only in selected groups of patients. The selection would be determined by clinical scoring systems. But when antibiotics are used, they can be useful. A Cochrane systematic review of more than 12,000 patients had showed that the antibiotics can reduce the symptoms of sore throat, measured at day 3 and also at day 7 of the illness. It can also reduce the incidence of peritonsillar abscess and other suppurative complications of acute pharyngitis to about 1/3 and can reduce the non-suppurative complications like rheumatic fever to about 1/4 of patients not receiving antibiotics. Penicillin has been the antimicrobial agent of choice for the group A beta hemolytic strep and still recommended by the most guidelines. The important thing is that the minimal inhibitory concentration of penicillin for group A beta hemolytic strep and other organisms has not shown any increase over the last 5 decades. For 50 years and more, there has been no signs of developing resistance to penicillin in the treatment of acute pharyngitis caused by group A beta hemolytic strep. You will see that most trials that we are going to go through have compared the penicillin as a gold standard with a variety of other antibiotics, for example, cephalosporins. There are hundreds and hundreds of different reports on the use of antibiotics, different classes, and the treatment of sore throat, not always with a very clear message and some with conflicting results. There are also dozens of controlled and randomized trials attempting to answer the same question. In this presentation, we will find evidence from meta-analyses of several systematic reviews from the Cochrane 2012, Cochrane 2023, and the NICE guidelines, the National Institute of Clinical Excellence 2023. We'll be analyzing outcomes, mainly based on the numbers needed to treat for different antibiotics for an additional beneficial outcome compared to penicillin. And we'll be looking at things like time to symptomatic or clinical cure, microbiological cure, clinical relapse rate, safety and adverse reactions, and other issues like costs and antibiotic resistance, to answer the question of which antibiotic, and also if there is any good alternatives in case of allergy or intolerance to that gold standard, and at what dosage, what frequency in a 24 hours, and the course length of the antibiotic. A recent Cochrane review and meta-analysis of different antibiotic treatments for group A beta hemolytic streptococci pharyngitis included into 19 different trials. 6 of them were comparing penicillin with cephalosporins, another 6 comparing penicillin with macrolides, and 3 comparing penicillin with carbazepine, and 1 comparing penicillin with sulfonamide, and another comparing clindamycin with ampicillin, and the last comparing azithromycin with amoxicillin in children. All these results were obtained from randomized, double-blind, controlled trials of different ages, including children. 9 of the trials were only or predominantly in children. And the results of the meta-analysis had showed that the effects of different antibiotics, including penicillin, cephalosporins, macrolides, erythromycin, and carbazepine, on the symptomatic improvement of patients with sore throats are fairly similar. All the antibiotics had caused some adverse effects, and the studies did not report on the long-term complications. Therefore, it was not clear if any particular class of the antibiotics was better at preventing serious complications, serious late complications, whether it is suppurative or non-suppurative. The findings suggest that in the context of preserving antibiotics, and given that the symptom improvement was fairly similar in all the examined groups, penicillin remains a useful antibiotic if the treatment of group A beta hemolytic streptococci pharyngitis with antibiotics is needed. The core message from the meta-analysis of the Cochrane 2023 is that there is no clinically important differences in the clinical outcomes, generally speaking, when different classes of antibiotics were compared to the gold standard, to the penicillin, in adults and in children. There would be few examples of some antibiotic classes showing better results than penicillin, either in adults or in children, in certain clinical outcomes. We'll go through them, but the general picture is this. There is no clinically important differences in the clinical outcomes between the antibiotic classes and penicillin. A Cochrane 2023 meta-analysis, including 5 trials of more than 2,000 patients, was comparing results of cephalosporins versus penicillin in the management of acute sore throat. The outcome here is the time for resolution of the symptoms after the treatment. The meta-analysis showed no difference in the children group. There was no difference at all. There was a slight but insignificant difference with the adults, and the final results had also showed a slight and insignificant results in favor of cephalosporin over penicillin. The results are insignificant as the confidence intervals of the odds ratio spans both sides of the 1. The numbers needed to treat for an additional benefit in the cephalosporin group over the penicillin group would be 20 more cases. You would think that treating 20 patients with cephalosporins instead of penicillin would incur additional costs to healthcare systems and also add to the risk of developing antibiotic resistance, particularly for cephalosporins as a broad-spectrum antibiotic. The evidence is of low certainty. If the outcome of the comparison is analyzing the clinical relapse rate between cephalosporins and penicillin, you would see a significant difference. In adults, cephalosporin had a reduced clinical relapse rate compared to penicillin. In children, there is no difference between the two groups. The total showed some benefits using cephalosporin in reducing the clinical relapse. The numbers needed to treat for the whole group would be 50 patients, and for the adults it would be more than 33 patients. These 4 trials included more than 1,300 patients. The certainty level is low. In another meta-analysis, this time the outcome is the side effects and the safety. There was no significant differences between cephalosporins and penicillin. Macrolides versus penicillin. This time, when the outcome is resolution of symptoms, there was no statistical difference between the two groups. When the outcome was the rate of clinical relapse, there was no difference between the two groups. But when the outcome was safety and adverse events, there was a significant difference. The macrolides has caused more adverse events in children than the penicillin. Carbazepine versus penicillin. There is a significant difference in favor of carbazepine in the children's group. There is a clear advantage in using carbazepine here. This advantage is still noted in the adult group, but it's not statistically significant. The total result is just about statistically significant, but for the total you would need 14 patients, numbers needed to treat, and for the children only where there is a clear significance, you only need 8 children to achieve better results in the carbazepine group. So, in conclusion, the Cochrane 2023 had showed that comparing cephalosporins and macrolides with penicillin had showed no clinically relevant differences in the symptoms resolution. There was low certainty evidence that in children, carbazepine is better than penicillin, is more effective for symptom resolution. It's unclear if any class of antibiotics was better at preventing serious late complications like rheumatic fever. And finally, in the context of preserving the antibiotics, given the results, penicillin remains a useful antibiotic in the treatment of group A beta-hemolytic strep. This is also the same conclusion and position of the National Institute of Clinical Excellence in their report in 2023 on the choice of antibiotic for sore throat. They state that there is no major difference in the clinical effectiveness between the antibiotic classes, including penicillin, cephalosporins, macrolides, sulfonamides in adults and in children in the treatment of group A beta-hemolytic strep positive sore throats. There was some statistically significant differences in some comparisons of the outcomes, like we have seen in the Cochrane meta-analysis, but the results, the absolute differences were small. There was no significant differences in the adverse events. A systematic review had earlier showed that a shorter course of late generation antibiotics, broader spectrum antibiotics including cephalosporins and macrolides, was associated with significantly more adverse events when compared to the classic 10 days course of phenoxymethyl penicillin. On the efficacy of the antibiotics, the NICE 2023 showed that the antibiotics were significantly effective in clearing the symptoms of more patients the 3rd day and the 7th day compared to a placebo, patients taking a placebo. At day 3, more than half of the patients on the antibiotic group were symptom-free compared to just more than a third of the patients who were on a placebo. The numbers needed to treat would be about 6. At day 7, most of the patients would be expected to be symptom-free at day 7 anyway, but still on the clinically positive cases requiring antibiotics, more than 87% of the patients were symptom-free compared to 82 patients on the placebo group. The numbers needed to treat would be obviously higher here because of the small difference at 21 patients. So overall, antibiotics shortened the duration of symptoms by about 16 hours in the 7 days period. On investigating whether antibiotics are more useful in some groups of patients than others, the meta-analysis of NICE 2023 showed that yes, antibiotics are obviously more effective if the patient has a group A beta-hemolytic strep positive throat swab. And that's the obvious thing. If they have the bacteria, then they are more responsive to the antibiotic than if they don't have, when they would have to wait for the spontaneous resolution of their viral infection. For that reason, the NICE 2023 recommended trying to select those patients who would benefit more from the antibiotics. Obviously, only a small minority of the patients would have a throat swab, and the recommendation is to use clinical scoring systems like fever, pain, or center criteria to identify people who are more likely to benefit from the antibiotic. The NICE 2023 Recommendation for the first choice oral antibiotics for adults would remain phenoxymethyl penicillin with a dosage of 2 grams a day, either divided like 500 milligrams 4 times or a gram twice a day for either 5 days. That's enough for symptomatic cure, but when bacteriological cure is needed, in case, for example, of recurrent sore throats or in areas in which rheumatic fever is still abundant, then a full 10-day course would give a better chance of microbiological cure. So that's the first choice. Alternatively, if there is a case of penicillin allergy or intolerance in patients who are not pregnant, then clarithromycin is the best alternative at a dosage of 250 to 500 milligrams twice a day for only 5 days. But if the patient is pregnant, erythromycin would be a better choice than clarithromycin. Are patients allergic to penicillin? This was estimated at about 11% in a retrospective review. But only a small fraction of these, only about 11% of those 11%, has a documented allergy experience and anaphylactic reaction. The incidence of true anaphylaxis has been reported at less than 1 in 10,000. And of course, history of atopic allergy, for example, asthma or eczema or hay fever, then the patients would have a higher risk of anaphylaxis to penicillin. Also, if there is a history of immediate hypersensitivity to penicillin, then patients may also react to cephalosporins and other beta-lactam antibiotics. Antibiotics in general would be associated with diarrhea in the area of between 2 to 25% of the cases. If the patient is allergic to penicillin, the best alternatives would be macrolides, but in some cases cephalosporins can be used, and if that's the case, a narrow spectrum rather than a wide spectrum cephalosporin should be opted for. The first choice for oral antibiotics in children and patients under the age of 18, according to NICE, would remain phenoxymethyl penicillin at reduced dosage. Between 1 and 11 months, the daily dosage would be 250 milligrams divided into 4 or 2 dosages. This would increase to half a gram in the group between 1 year and 5 years, and a gram between the age of 6 and 11 years, again either 4 times a day or twice a day, for either 5 days for clinical cure or 10 days for bacteriological cure. In the age group of 12 to 17 years, it's up to the adult dosage of 2 grams penicillin per day. The 5 days is enough for symptomatic cure, but bacteriological cure could only be achieved at a better level with a 10 days course. The alternative first choice for children and patients under the age of 18 would still be almost the same. Clarithromycin, like in adults, at a reduced dosage, and in those very small group of patients under 18 who would be pregnant, erythromycin would be the preferred choice. The efficacy of antibiotics in reducing the incidence of the suppurative complications of acute tonsillopharyngitis was again confirmed by the NICE 2023. Complications like acute otitis media, acute sinusitis, and peritonsillar abscess would be reduced within 24 days of the sore throat significantly in the group who are taking the antibiotics. But the numbers needed to treat is high at 200. That is to say, 200 people would need to be treated by antibiotics to prevent one more single suppurative complication like acute otitis media or sinusitis or a quinsy. And that's why the advice of the NICE was not to use antibiotics specifically to prevent or reduce the incidence of suppurative complications. Antibiotics are also very useful in reducing the incidence of the non-suppurative complications of acute pharyngotonsillitis like rheumatic fever. the antibiotics reduced the incidence of rheumatic fever by more than 2/3 compared with the group who had not had the antibiotics. But there was no statistically significant reduction in other non-suppurative complications like acute glomerulonephritis in patients taking the antibiotics. In general, the incidence of rheumatic fever, acute rheumatic fever, has continued to decline in the Western societies, but that's not the case worldwide. Amoxicillin is one of the fastest action oral antibiotics and is also more palatable for children. But NICE 2023 had noted the increasing risk of resistance to amoxicillin. This risk is greatest in the first month after use, but is detectable for up to a year. In addition, of course, the use of amoxicillin in cases with glandular fever or suspected glandular fever is not advisable at all because of the erythematous rashes and reaction. Therefore, the advice from NICE 2023 is that amoxicillin should be avoided, and ampicillin-based antibiotics, including co-amoxiclav, should be avoided as a first-line treatment in the cases of sore throat. The gold standard for the use of phenoxymethyl penicillin is 4 times daily dosages. NICE 2023 had looked on whether twice daily dosage would be as effective as 4 times daily dosage for the same daily dosage of 2 grams, for example, in an adult. The twice daily dosage would obviously have some advantages. It would support medicine's adherence for people who would find it difficult to take the dosage at 6-hourly intervals before food, such as children at school, for example. On the other hand, the levels of the phenoxymethyl penicillin would drop below the minimum inhibitory concentration if it has to wait for 12 hours on the twice daily dosage. But the NICE 2023 had noted that streptococci are highly sensitive to the antibiotic and that the penetration of the antibiotic in the sore throat tissue is quite good. Therefore, even small concentrations of the antibiotic will still treat the infection. And the advice was that twice daily or 4 times daily dosages could be used, providing the same total daily dosage of, for example, 2 grams in the adults. For how long should you be using the penicillin? NICE 2023 had noted that using the phenoxymethyl penicillin for 5 to 7 days would have a significantly lower cure rates in terms of microbiological cure compared with the standard of 10 days. And there was no significant differences in the clinical cure and the control of the symptoms or the relapse rate, the recurrence rate. But in cases of recurrent infections or in areas where rheumatic fever incidence is still high, a 10 days course that is going to achieve a much better microbiological cure is still indicated. This will increase the likelihood of microbiological cure significantly. As a more severe condition of acute pharyngotonsillitis require a more aggressive dosage of penicillin. This report from Sweden was looking at some more severe cases who scored high with the clinical scoring system of center score, like score 3 and score 4, taking 2 different strategies of phenoxymethyl penicillin, either 4 times a day for 5 days or 1 gram 3 times a day for 10 days to see if the more severe symptoms could be better controlled by a more aggressive dosages. And the results showed that yes, the intense treatment for the more severe symptoms could actually give some clinically beneficial effects. Patients with high clinical scores who received the 4 times a day penicillin with 800 milligrams for only 5 days reported recovery earlier than those who were taking 1 gram only 3 times a day, even for a longer period. So in short, the more severe group who had received the more intense course had resolution of their symptoms earlier. They also, when compared the two groups, taking throat pain as a single symptom, it was relieved 1 day earlier in the more intense group than in the less intense group. There was no difference in the side effects between the two groups, and the general conclusion was that intense treatment 4 times a day for 5 days is better than less intense treatment of 1 gram 3 times a day for a longer period of 10 days. Although there has been no much difference in relapses or side effects, this entails actually reducing the total dosage of the penicillin by 14 grams because you are only giving it for 5 days rather than 10 days. This same question of whether late generation antibiotics used for shorter periods could achieve results compared to longer courses of the gold standard, the penicillin, was addressed earlier by the Cochrane 2012 and showed similar results in large trial, more than 13,000 patients. It showed that using the late generation antibiotics could achieve some beneficial clinical results, although very modest, like it would have less periods of fever, less by 1/3 of a day compared to the standard penicillin for 10 days, could also achieve control of the sore throat for half a day earlier compared to the penicillin 10 days, and lower risk of early clinical treatment failures. And there was, on the other hand, an increased risk of late bacteriological recurrences and the short duration late generation antibiotics treatment. Very clear significance here, indicating that in cases of recurrent sore throats and in areas of high rheumatic fever, the longer duration and the gold standard of penicillin for 10 days is superior to shorter duration with intense treatment. By this, we come to the end of this presentation on which antibiotic to choose for the treatment of acute sore throat in the cases of acute pharyngotonsillitis. Assalamu alaikum.